Here, the other problem is each ventilator does manage how they deliver differently. So you don't want to have too many ventilators in your NICU, different companies. Stick with one or two ventilator companies, because each one does a little bit differently, and you need to know how your machine works. Here is, most of the time, this is the pressure control, SIME, or volume control, SIME. Pressure support ventilation, PRVC, pressure regulated volume control, assist control. Again, assist control can be pressure or volume, and APRV. Very rarely we use APRV in the NICU. It's used often in the PICU. You really don't need to use APRV in the NICU unless baby has very severe lung disease, severe BPD. This is called airway pressure release ventilation. Not many ventilators offer this mode anyway. Trigger, what starts the breath? Could be patient or could be time triggered. Most ventilators will time triggering. Limit, what do you limit? You can limit either the pressure or the volume, depending on. Cycling up, when you switch from inspiration to expiration, it can be time cycled or flow cycled. Flow cycling is the best. If we have a ventilator and that has flow cycling, you should turn it on. So you set an inspiratory time of 0.4 seconds, for example. We do 0.45, whether it's small baby or big baby, really doesn't matter. Then what we do is flow cycling at 10% of the peak flow. I'll show you later on the graph. So when the peak flow decreases to 10% of the peak value, that means the lung is completely full. There is no reason to keep the valve closed, your inspiratory time. So automatically it opens to exhalation and the baby can breathe out. You really get good synchronization if you flow terminate it. So keep the flow termination minimum 10%. Sometimes you may use 5%, but most of the time to keep it simple, keep the flow termination at 10% of the peak value. The ventilators will give the option, 5%, 10%, 15, 20, 25. Don't go too high. 10% is pretty good. Okay, that's another way of improving synchronization. Flow. How does the gas come out of the ventilator? In a pressure-controlled machine, it's a decelerating flow. Flow gradually ramps up. As the lung gets full, the flow decays, called decelerating flow. Whereas on a volume mode, anytime you switch to volume control mode, the flow becomes constant. The ventilator increases the flow, holds it until the duration of inspiratory time, and then decrease the flow back to 0, and then allows the lung to empty. Exhalation stops. Okay. And fortunately, all these modes, spontaneous breathing is allowed. Baby can breathe spontaneously, whether you're an SIME, pressure support, PRVC, assist control, or APRV. Okay. So pressure control is decelerating flow. Volume control is constant flow. But most ventilators nowadays can change the flow pattern to decelerating flow too. Here is a PRVC, for example. You can have a decelerating flow. Some ventilators will give the option. What is the advantage of decelerating flow? Decelerating flow is physiological when you take a breath in. Okay. Constant flow means a high flow rate, and it's like blowing a fan in front of the baby or the TT tube. So it causes more turbulence. That's why if you can have a decelerating flow setup, even on a volume control mode, you should set it up. Again, some ventilators will allow you to do that, some do not.